Hello and welcome to Talking About Tumors with Ryan and Ryan. I'm Ryan Holstead.
And I'm Ryan Quinn.
And we're back together to move forward in our breast cancer discussions. Today talking about the approach to hormone therapy in adjuvant setting.
So we took a few weeks off after the birth of our son, so shout out to all the parents out there. Parenting is way harder than oncology, as we're quickly learning.
It's amazing what something so small that cannot walk and basically only eats and sleeps can accomplish through the course of a day.
Yep, maternity leave is no joke. But we're happy to be back, and we're going to be, again, talking about adjuvant endocrine therapy.
So as many of you know, the most important things when looking at early breast cancer are the hormone status, such as estrogen markers, as well as HER2 status. Obviously, there's some overlap with HER2 and ER-positive tumors. We're going to be sticking purely to an endocrine therapy discussion today, and we'll later on, when we get through our HER2 discussions, get a little bit more into the weeds on what to do for those triple-positive tumors.
Yeah, so adjuvant endocrine therapy is used again for the hormone positive, which is defined, as we said, either ER positive or PR positive, and that's anything greater than 1% on the pathology report is considered positive.
The link between estrogen and development of breast cancer has been well demonstrated as far back as the early 1900s. Prior to modern approaches to management, experimental oophorectomies had shown some protective role against breast cancer recurrence. As mentioned during the Bonadonna trial, when we looked at the use of CMF in adjuvant setting, we did see that there's an increased benefit in premenopausal women, which had raised further the question that there may be some benefit due to the suppression of ovarian function. Sort of surreptitiously?
Surreptitiously.
Interestingly, in the 1950s and 1960s, a series of compounds were made that were initially with the goal of being contraceptives. These are actually ineffective and did not serve their purpose and were put quickly on the back burner. They were found to actually have some stimulatory function in ovulation. These later became known as SERMs, which is selective estrogen receptor modifiers, which are partial agonists, which prevent fully activation of an estrogen receptor, which leads to partial inactivation of an overactive receptor, but stimulation of a otherwise somewhat underactive receptor. The most famous of these being Tamoxifen. In 1972, the estrogen receptor became identified on the surface of breast cancer due to developments in histological stains. This served as a selection criteria that was quickly incorporated, and patients who were positive of this were incorporated into trials looking to see if tamoxifen has a beneficial role in both metastatic and early breast cancer.
Tamoxifen is given as a dose of 20 milligrams daily. So the two most important clinically relevant side effects, although they're very rare, are VTE, so venous thromboembolism, including DVT and pulmonary emboli, as well as the development of endometrial cancer. And this is especially more common in older patients, although again, still very rare. Other things that are more common, but more manageable and less serious: hot flashes, sexual dysfunction, vaginal dryness, so menopausal symptoms.
Although it does cause menopausal symptoms, it's important to know that this does not push patients directly into menopause. So if you have a premenopausal patient on tamoxifen, it's important to tell them to use contraceptives if they're sexually active, as they can become pregnant, and tamoxifen has shown to have poor outcomes in the setting of pregnancy. Also, somewhat interestingly and slightly different than the aromatase inhibitors, which we'll be talking about shortly, is that the risk of thrombosis of tamoxifen can also involve some major thrombotic events, and people can have, although quite rare, people can have an increased risk of heart attacks as well as strokes.
So one of the first major trials looking at tamoxifen in the adjuvant setting was in 2011, looking at tamoxifen versus placebo, a total of 5 years of tamoxifen versus 5 years of placebo. And this was looking at both premenopausal and postmenopausal patients. This was actually a meta-analysis of about 20 trials looking at tamoxifen in the adjuvant setting. They found that at a median follow-up of 13 years, there was a decreased recurrence risk of breast cancer, as well as decreased breast cancer mortality.
Yeah, the relative risk of recurrence in the meta-analysis was shown to be 0.61. So if you keep in mind that, that's pretty much identical to the benefit from chemotherapy. If you remember, we had about a 30% risk reduction and then some added benefit with the second and third generation chemotherapies.
It did decrease mortality by about 1/3 during the 15-year follow-up. And for both recurrence and mortality, the benefit was really more significant in preventing early recurrences. So the relative risk was more significant in the earlier years, so years 0 to 10. When they looked out past year 10, there wasn't as much of a benefit.
Yeah, really, really remarkable. By decreasing the breast cancer mortality by about a third, we've actually improved overall survival as well by about 20% in this population.
Yeah, and they did have about 80% compliance in these trials, which I think is similar to what I've personally seen in the clinic in terms of patients that are able to complete the 5 years of tamoxifen.
So as interest grew in using this medication and trying to optimize its use both in the adjuvant and metastatic setting, there was interest of further improving upon the efficacy of tamoxifen, and aromatase inhibitors were next developed. So rather than just partially blocking the estrogen receptor, as the SERMs do, aromatase inhibitors actually go to the source and prevent all production of estrogen from the adrenal glands. In the menopausal setting, although the ovaries are no longer making estrogen, the adrenal gland continues to play a role in steroid production, including estrogen. So these drugs were developed and were shown to be very effective at further decreasing estrogen, primarily in the post-menopausal patients. We cannot use aromatase inhibitors if someone's premenopausal because it actually leads to overproduction of estrogen in the ovaries. So it can kind of go against our goal.
So speaking about menopause, the NCCN does have a definition that they use to describe menopause because although, in everyday life it may seem relatively straightforward if a patient is menopausal or not, if a patient's on tamoxifen or other ovarian suppression, it can get kind of confusing. So the definition of menopause is anyone greater than 60 years old, we automatically say that they're in menopause. Less than 60, if they had a bilateral oophorectomy, makes sense, then we would call them menopausal. Anybody who hasn't had menses for 12 months, and when you check their estrogen level, it's in the menopausal range, and they are not on any ovarian suppression or any tamoxifen, that would also be considered menopausal. And then lastly, for a patient who's on tamoxifen, if they had no periods for 12 months and you check their FSH and it's increased and estradiol is decreased in the menopausal levels, that would also be considered menopausal. This is important because when you're deciding what adjuvant endocrine therapy to give, it's extremely important to know the menopausal status. So especially for new fellows, whenever you're presenting a patient in clinics you're attending, it's always important in the one-liner to say, 55-year-old female, and you always want to specify menopausal or postmenopausal. I know when I first started the beginning of my fellowship in the breast clinic, my attending was always asking about the menopausal status, and sometimes I, forgot to ask. So something to keep in mind when you're in clinic.
And on the topic of keeping good records and relevant information, I didn't mention this during our overview of breast cancer, but it's important in your history taking to take a good gynecological history, which many of us in internal medicine have not done routinely prior to this point. So things such as age of menarche, age of menopause, total number of births, age of earliest birth, whether or not a patient has ever used oral contraceptives and how many years, and whether or not they use hormone replacement therapy a number of years. While this doesn't change what we do once someone's developed breast cancer, it does help build some better understanding of risk factors, and is important, especially if you're working in an academic center, for taking a thorough history. So these newer agents were compared to our old friend tamoxifen. Because tamoxifen had been shown benefit over 5 years, they were compared to tamoxifen being given for 5 years. And so these did show some improved overall outcomes, primarily in the setting of breast cancer-related mortality. So 5 years of letrozole versus 5 years of tamoxifen showed 10-year breast cancer mortality with a relative risk of 0.85, which was statistically significant. This translates into an absolute 10-year overall survival of 76% versus 78.7%, so a little bit smaller when we get to overall survival, and a 10-year recurrence risk of 23 versus 19%, so 4% absolute risk of breast cancer coming back, and an improvement of overall survival from breast cancer. Modest, but remember this is in addition to what is already a good benefit from tamoxifen. Of course, this comes at a slightly different toxicity profile, which may help weigh your hands on which treatment you're going to decide upon.
Now, there are 3 different aromatase inhibitors that we use: anastrozole, letrozole, and exemestane. And unlike the CDK4 inhibitors, where we don't have any randomized trials directly comparing them, we actually do have some data directly comparing the efficacy of the 3 aromatase inhibitors. and they actually have shown to be very similar in efficacy. So you can really choose whichever one. And if somebody has side effects to one, you can feel pretty comfortable switching to another to see if they tolerate that. So in terms of side effects, one of the most common things that we see is musculoskeletal pain and stiffness, as well as bone pain. You may see this being referred to as AIMS, which is AI-associated musculoskeletal syndrome. Sometimes it can be difficult to tease this out from just regular arthritis. Women that are started on aromatase inhibitors tend to be older and around the age that they would be developing osteoarthritis anyway. And we'll see this in the studies. Even the placebo arm, many of them complained of musculoskeletal pain. But it is something that can definitely come up with the aromatase inhibitors. And you can use NSAIDs for this. Exercise has been shown to be helpful. Even things such as duloxetine, SSRI, can also be helpful in this. And again, if all else fails, you can always switch to a different AI or even switch to tamoxifen if they're not tolerating any of them. Other things that we see are hot flashes, sexual dysfunction, vaginal dryness, decreased libido. And we don't always ask about this. Sometimes, we're notoriously bad at asking about sexual side effects, but always something to keep in mind because patients may not be upfront about this, but it definitely has quality of life implications. Another major side effect is low bone density, so osteoporosis. So you want to check a DEXA periodically on these patients just to make sure that they're not developing osteoporosis. Again, they're also women that are in the age range of developing osteoporosis anyway, but there has been data that shows that AI can speed this process up. And the last thing is elevated cholesterol. You want to make sure that these patients have a primary care doctor that's, checking their cholesterol and starting them on, medications if they need.
Yeah, so just to kind of build upon that, osteoporosis, definitely something you're going to run into later on if you treat enough patients with these medications. Be very mindful of bone health. In a bit, we're going to get into extended AI therapy, and I think the biggest risk to be aware of if you're going to be going beyond 5 years is further increase of fractures. And, especially when we're talking about marginal gains, we want to make sure we're not leading to someone 20 or 30 years down the road having a serious hip fracture, which can be life-threatening. In addition to what Ryan's already said about management of the musculoskeletal pains, I think it's also to be aware of ways to monitor and manage the other side effects as well. So as far as hot flashes, it's good to be aware of certain things that can precipitate that. Caffeinated beverages, spicy foods being some of the most common ones that patients may be using, and to provide them on education on ways of reducing that risk so that they might be able to tolerate the therapy better. One thing I always mention to women before I start the therapy is I asked how their menopause went. If people had a very significant symptom-based menopause or people had a very mild menopause, sometimes that can predict how they'll end up tolerating the AI. Lastly, as far as sexual dysfunction goes, many cancer centers now have consulting providers who provide sexual health consultations. If you do not have that in your area or a GYN, you probably will have gynecologists who can help out with this. In a pinch, it's always worth discussing the role of topical lubricants. Although a central dogma for estrogen-positive breast cancer is to not give any estrogen-containing therapies, it's also important to be mindful that if you want patients to be taking a therapy for 5 to 10 years and they're not going to take it due to how significant these side effects are for them, you may consider using a low-dose topical estrogen-based lubricant, although this theoretically could increase the risk of recurrent cancer. So certainly a patient-centered discussion and would not be the first thing I would reach. So let's say you run into a patient who you meet in the perimenopausal state. Maybe they're 50, 52. They had a period in the last 6 to 8 months. Very likely over the course of 5 years, they're going to be progressing into menopause. And one of the questions is, if the AIs give a slightly better benefit, what can we do for these patients? And there were a number of trials done that looked at doing what's called a switch strategy. And there's many of these. Some use tamoxifen for 2.5 years, followed by 2.5 years of AI. Some use tamoxifen for 5 years, followed by 2.5 years of AI. And these did show that no matter when you switch, if you switch and complete 5 to 7.5 years of therapy, with at least half of that being AI-based treatment, you can kind of make up for that absolute benefit difference. So certainly worth after 2.5 years reevaluating menopausal status if you have a patient on tamoxifen.
One practical issue is, after surgery and with chemotherapy and radiation that these patients may be getting, when do we start the endocrine therapy? Most centers typically start the endocrine therapy after the completion of chemotherapy. So patients that are going to be getting adjuvant chemo after their surgery, we would wait until after they complete chemotherapy before starting the endocrine therapy.
And this is based upon evidence that showed giving tamoxifen at the same time of chemotherapy actually led to worse outcomes, raising the thought that potentially putting these cells into a hibernation state made the chemotherapy less effective by having fewer dividing cells.
Yeah, exactly. There's thought that, if you have two medications at the same time, if you have toxicities, you don't know which one it's causing, and it may cause patients to want to stop the AI early, even though the toxicity is from the chemotherapy. Now, patients that are HER2 positive, which we're going to get to in future discussions, you can give the endocrine therapy with just the trastuzumab. So if somebody is getting chemotherapy with trastuzumab, but then they're going on to complete 1 year of just trastuzumab, you can start the endocrine therapy with the trastuzumab. You don't have to wait for them to complete trastuzumab before you start. In terms of radiation, now this is a little bit more controversial, and it really sometimes is center dependent. There's really no or conflicting data that if you give endocrine therapy with radiation, it will change the outcomes. There seems to really be no impact on outcomes with endocrine therapy when it's given with radiation, although many centers still do wait, including the center I'm at. We wait until after they complete radiation to start endocrine therapy. But there's not great data either way for this.
You'll ultimately defer to your radiation colleagues, as they'll be the ones administering the treatment, and there certainly isn't significant harm delaying hormone-based therapy for a month and a half. In my practice, if I don't really know the radiation doctor's preference as well, as I give a patient a prescription and just tell them to meet with the radiation doctor first and find out when they'd like to have them start the therapy. Also, there's kind of the practical issue. You start a tamoxifen or aromatase inhibitor and have significant side effects. Some patients may think that this would be related to the radiation, may not want to complete the radiation, which has significant benefit for local control. So that can also be part of the reason you may want to wait. We'll be talking about the natural history of triple-negative breast cancers and HER2-positive breast cancers later, which tend to have an aggressive early recurrence type of process. Hormone-positive cancer tends to, although its highest chance of risk is in the first 5 years, these are famous for coming back even decades after the initial diagnosis. And there are these sort of indolent estrogen receptor positive cells that can kind of show up many years down the road. Usually when estrogen receptor positive breast cancer occurs, that's within the bones. Due to this, there was much interest in seeing if extending these hormone-based therapies can further improve our chance of cure and prevent these late recurrences, which can sometimes be catastrophic and incurable.
So there are two similar trials looking at this in the setting of just tamoxifen only. So either 5 years or 10 years of tamoxifen. This was the Atlas and the Atom trials. And these trials both showed decreased risk of recurrence with 10 years of tamoxifen as opposed to 5 years. And it also did improve, although modest improvement in mortality, 2.8% in the Atlas trial. It did show an increase in endometrial cancer with the longer duration of treatment of tamoxifen, as well as increase in the total number of pulmonary emboli, which makes sense if you're getting it for twice as long. Although there was actually no increase in strokes or cardiovascular events.
One of the limitations of the Atlas trial is previous to our estrogen receptor positive testing era, so only 6,000 of the 12,000 patients, really large trial, were known to be ER positive. They did do a subgroup analysis, and among the estrogen receptor positive patients, there did seem to be an overall survival benefit with a hazard ratio of 0.87, invasive disease-free survival benefit of 0.84. This was then naturally followed by a number of trials looking at that after 5 years of tamoxifen, doing 5 years of letrozole, kind of like a full 5 years followed by a 5-year switch. One of these trials, the MA17 trial, looked at 5 years of tamoxifen followed by 5 years of letrozole. And this did find an improvement in disease-free survival and prevention of contralateral breast cancer with a hazard ratio of 0.58. And there was also overall survival shown in this study, specifically for the patients who were node positive. So node positive patients, there was an overall survival benefit of 0.61. So definitely a good argument that if you have a patient who's done their 5 years of tamoxifen, if they're a high risk for recurrence, such as node positive patients, to try to get an AI as part of their treatment plan. The other thing I also liked in this trial, they provide some nice data that gives us ways of providing education to our patients. And they did find in patients who are lymph node negative who stopped tamoxifen after 5 years had approximately a 2% risk of recurrence per year. And the patients who were lymph node positive, that was about a 4% risk of recurrence per year. And then the extending to 10 years with the additional letrozole reduced that by half. So when I talk to patients, if they're lymph node negative, I say, if we were to stop after 5 years with just tamoxifen alone, it'd be about 2% per year. Can bring that down to 1%. If they're lymph node positive, 4% per year, down to 2%. And that can sometimes help put these decisions in perspective, especially for your patient who has very significant side effects on their therapy.
So now what about patients who already completed 5 years of an AI? Do they benefit from an additional 5 years? This was studied in the MA17R trial, which looked at patients who completed 5 years of letrozole and randomized them to an additional 5 years or a placebo. And this study did show an improved disease-free survival. However, it did not show any overall survival benefit. And in fact, no trials looking at extending the duration of aromatase inhibitors have shown any increased overall survival, although they have shown a decreased risk of recurrence. So in the MA17R trial, the disease-free survival of 91% with just 5 years, and then when you went to 10 years, it was 95%. It also showed decreased risk of second primary cancers, as well as contralateral breast cancer, although it did show, and something to warn your patients about, increased risk of osteoporosis and bone fractures.
The annual benefit of extending an AI from 5 to 10 years was given as part of the risk of having a contralateral breast cancer, which was given at a risk of 0.5% per year for patients who had only 5 years of letrozole versus 0.25% per year for those who extended to 10 years. So when we're talking about the benefit from a patient who started off with 5 years of AI, our benefit's really reducing the risk of a secondary or contralateral breast cancer, which understandably may be beneficial to patients, of course, avoiding future surgery and the stress that comes with this, although that for each patient may be counterbalanced by the toxicities with the AI, as well as the small benefit, which just may not be worth it for them to continue on the therapy. It's important to note that this benefit was independent of lymph node status. So even if someone's lymph node positive, we did not see evidence of overall survival benefit on the extended therapy. More recently, an Austrian trial had looked at whether or not we can get away with doing a bit less than 10 years. And this study randomized patients after 2 years of extended AI. So these are patients who had 5 years of endocrine therapy, were randomized to either having 2 years of an aromatase inhibitor or completing for the total of 10 years. And this did find no significant difference. Subgroup analyses depend regardless of individual what agent was given for the first 5 years appeared to make a significant difference. So there is certainly an argument, if you are extending, to maybe consider doing that for only 2 additional years rather than a full 5, with the understanding that this may provide some additional benefit to prevent osteoporosis.
So important thing to note about this study is that about 2/3 of the patients had just stage 1 disease, and nearly everybody had stage 1 or 2 disease. So this was looking at a pretty low risk group. So something to keep in mind when you're interpreting the results and applying to your patient. So for premenopausal patients, there were also 2 studies looking at the addition of ovarian function suppression in addition to either tamoxifen or an anastrozole or an AI.
These are 2 independently run trials, one called SOFT, one called TEXT, although given their very similar design, ended up being analyzed together in 2 subsequent publications, although there are some certainly relevant differences between the individual trials. So these trials built upon the previous, if you remember, we talked about way back in the 1990s, we were talking about doing oophorectomies in patients. One of the questions was, in premenopausal patients, now that we have effective hormone-based therapy, does doing oophorectomy or a medical similarity, which would be ovarian suppression using a LHRH agonist, such as goserelin or leuprolide, is this able to further benefit our premenopausal women and reducing the chance of disease recurrence?
So yeah, these studies used monthly GnRH agonists. So not the 3-month schedule like we'll see sometimes being used in something like prostate cancer. Monthly GnRH agonists in addition to either tamoxifen or an AI. And it was stratified based on whether or not patients were considered high risk enough to receive chemotherapy.
There's certainly going to be some limitations when we talk about the final data, because as these were different trials, they couldn't be directly compared with any statistical significance.
So they did find that in patients that did receive chemotherapy, the addition of ovarian function suppression did improve the disease-free survival rate, both when it added to exemestane and to tamoxifen. It also did decrease distant recurrence. Interestingly, when we looked at the AI, there was actually no increase in overall survival compared with AI and ovarian function suppression versus tamoxifen alone. However, when you looked at tamoxifen plus ovarian function suppression versus tamoxifen alone, there was an overall survival benefit.
Worth noting that both the SOFT and TEXT trial looked at 5 years of therapy. For raw numbers, the 8-year follow-up study showed invasive disease-free survival improvements. Looking at tamoxifen alone was 79%. Tamoxifen with ovarian suppression was 83%. Exemestane with ovarian suppression was 85.9%. Looking at the patients who did not receive chemotherapy, which were mostly lymph node negative patients, the invasive disease-free survival was 87.4%. Versus 90.6% in the tamoxifen ovarian suppression and 92.5% in exemestane ovarian suppression. And then looking at the chemotherapy containing arms, this invasive disease-free survival benefit was much larger, going from 71 to 77 to 80.4%. So although the relative benefit was increased, the absolute benefit increases the higher risk disease you have. And there certainly appeared to be a trend towards some survival benefit, and as Ryan mentioned, statistically significant in the SOFT trial, looking at ovarian suppression, and this really seemed to benefit mostly our lymph node positive patients. So in the chemo or the patients who quote unquote received chemotherapy. So looking at the patients who received tamoxifen alone, 8-year overall survival is 85% versus 89% with tamoxifen ovarian suppression, and then the exemestane was 87 versus 85%.
There did also appear to be an increased benefit in the younger patients. So if you were less than 35 years old, they did do a subset analysis in the SOFT trial, patients less than 35. And the addition of ovarian suppression with the exemestane did increase the disease-free survival. So with tamoxifen alone, it was 68% at 5 years. And then with exemestane plus ovarian suppression, it was 83%. These patients were mostly high risk. In fact, greater than 90% of them did receive chemotherapy.
Understandably, the major increased risk here was the risk of osteoporosis. In patients with tamoxifen alone, risk of osteoporosis was 13%. With the tamoxifen ovarian suppression, that went up to 28%. And with exemestane, this was up to 42%. So not benign treatments when we're talking about bone health. From personal experience treating these patients, putting someone on ovarian suppression prior to menopause is not always an easy go around. These patients can have significant menopausal symptoms. So sir, my personal preference is to really reserve this in the groups that seem to benefit the most. So a very high risk young patient, lymph node positive, someone who we want to give chemotherapy for, continue increasing their margins of benefit by doing ovarian suppression. In addition to using LHRH agonist, of course you can do a new oophorectomy. There's also the possibility of doing ablative radiation to the ovaries. Probably from a clinical practical perspective, do the LHRH agonist first. It's reversible. So if the patient can't tolerate being in menopausal status at that age, you can then stop that medication and just continue on the hormone therapy alone. If they tolerate it after a couple months, you can open up that discussion about actually having a surgical or radiation-based procedure. So bottom lines are endocrine-based therapies are incredibly effective options for our hormone-positive breast cancer patients. They've shown in the adjuvant setting to be as good as chemotherapy, and in addition to chemotherapy, further increasing our overall survival. This has played a huge role in improving overall outcomes in patients and reducing risk, both risk of recurrence and risk of death from breast cancer, as well as overall survival. And which treatment you reach for and the length of treatment is going to depend on your patient's menopausal status as well as risk factors, often denoted by lymph node positivity or if they had a high enough risk that you would choose for chemotherapy.
Yeah, so for premenopausal patients, anyone who is high risk, so again, lymph node positive or very large tumor, especially patients that are less than 35 years old, this is when you would reach for your ovarian suppression plus either tamoxifen or an AI, with some data suggesting an AI may be more effective. For patients that are low risk and older patients, this is when you would reach for tamoxifen alone with the option to switch to an AI once these patients do become menopausal. And especially when they're on tamoxifen, you would want to make sure that you're checking the estradiol and the FSH levels because the absence of menses is not always a reliable indicator in these patients when they're on tamoxifen.
In your post-menopausal patient, you're going to likely reach for an AI, exemestane, letrozole, or anastrozole are all equivalent. The only reason you often would be using tamoxifen in this setting is if they're unable to tolerate the AIs and you want to try to see if a different toxicity profile is more beneficial. If a patient has received tamoxifen initially, ideally you want to get in at least 2.5 to 5 years of an AI once you can do the switch, as this has shown both survival and disease-free benefits. If someone's had 5 years of AI, the added benefit of additional years is really more for decreasing contralateral or secondary primary breast cancers, and this is really a patient-related discussion. You'll find you'll develop your how you like to present this data to patients, and you'll see that many people will have different opinions on how they like to proceed. So we managed to do this with only one break from baby, and we're going to continue to try to keep on pace as we move forward with the rest of the breast cancer discussions. Next episode, we're going to talk about some additional tools we have to improve our care in the adjuvant setting for hormone-positive disease using recurrence risk scores, such as the Oncotype, as well as some of the novel therapies and their emerging role in this setting.
Yep, should definitely be an exciting talk with the latest and greatest and some new data coming up. And we should probably wrap this up because both of us wearing noise-canceling headphones with a newborn in the house, probably not the best idea. Really parents of the year right here. So we'll see you next time.
Thanks so much.
For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
Opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.